Hi, welcome back to the CODA podcast. I'm Ollie Flower.
And I'm Roger Harris.
Here's a podcast from our CODA 22 event, which I think we really feel was our best content yet. It was our best event yet, and it was so good to see everyone back together again after such a long hiatus, right?
So good. It was friggin' awesome to be back together. So much to be proud of. Agree. Maybe our best content ever. And how about having a Climate Active or Australian Government Climate Active certified carbon neutral event? That's a first.
It was one hell of an achievement, that.
Massive achievement. And there'll be lots more on the website that you can track down about how we did that.
So please go to the website, check out the other podcasts and video content, the YouTube channel, and you can find us wherever you get your podcasts. And do share it with your network, tag us on socials, and spread the word, because this is the last CODA event and it's been one hell of a ride. So thank you for everybody who's been part of it.
Yeah, an absolute privilege to have been part of it. For more on the sort of winding up of CODA, check out on the website, and hope to see you all soon.
See ya.
Thanks, Karin, for going over to the Cube. So this is the last part of the cure session, and Karin is going to be talking about sepsis and antimicrobial resistance. Thanks, Karin.
I'm an antimicrobial steward for 20 years, an infectious disease physician, and for 20 years I've been really working to focus on antimicrobial stewardship. And you say, well, what's that word? I know there's an AMS team in my hospital there. Well, it really is a systems approach to ensuring that we have judicious use of antimicrobials. It is not just about stopping antimicrobials. We're not the antimicrobial police, but it is around having systems to monitor, to undertake surveillance, to identify data for action, to ensure that our clinical guidelines meet good stewardship principles, to ultimately improve patient outcomes, and it does. It actually does. And so you would be, I'm sure, aware that antimicrobial resistance is one of the global challenges of our lifetime. And the use of antimicrobials, to be able to continue to use our antimicrobials, is what makes it possible for us to have our patients to have bone marrow transplant, surgery, chemotherapy. And we have a limited armamentarium. Most of the pharma companies have stopped making new antimicrobials, and so it's even more important now. And then there's also the key issues in the low middle income countries in making sure that antimicrobials are available there as well. So there's an element of supply. And so every country in the world does have a national action plan, and in Australia, the second objective of our plan is actually to ensure that we embed antimicrobial stewardship. And so that is the narrative around AMR. I tend to look at it much more as a patient safety focus. The competing narrative is that of sepsis. Again, a global challenge in which we've already seen the videos from around the world around the deaths and the lack of comprehensive actions, and frustrating for all of us who work with sepsis that we still don't have a really strong national approach. And it's not surprising that we see these daily newspaper articles, these terrible stories from Fiona's own experience that are really distressing for us to read. And so it's not that surprising that we can sense that there is an absolute fear for our prescribers in primary care and hospitals, in aged care. This absolute fear is what they do if they do not give antimicrobials for suspected infection. We know that sepsis is a time-dependent thing, and they also are fearful that if they undertreat, then the patient is not going to do well. The flip side of the story is that sense of complacency. Okay, we're world experts in VRE, but we really don't have a huge amount of the multi-drug resistance that we see in some of our neighbours. Most of us will have a handful of patients, maybe one or two a year, where they have very difficult to treat resistant infections, but generally speaking, we're very fortunate in Australia. And so that concept of complacency, maybe leading to overdiagnosis and overtreatment, doesn't really sort of link to this potential future risk of AMR. But I'd like to bring it back to the patient, and the patient is at the centre here, and that antimicrobial stewardship and sepsis management really is actually about the patient first. So this is the next thing. I'd like to take you through to a typical Friday night phone call, and just again coming back to that knowledge gap and perhaps awareness and recognition of what sepsis is. And it's the 11 o'clock phone call from one of the HMOs on overnight. Oh, hi, Prof. It's Simon. I just wanted to have a chat to you about some antibiotics. So, okay. What about the patient? Oh, he's had colorectal surgery about 5 days ago. He's got a really red-looking wound. We're going to do a CT, but we just thought we'd better start some antibiotics. I said, okay, what are his obs like? Oh, he's fine, he's stable. So can you actually tell me his obs? What's his respiratory rate? What's his pulse rate? I said, okay, his pulse rate's 110, respiratory rate's 26. I said, okay, do you think he could have sepsis? Oh, maybe. Have you done a venous blood lactate? No. What about cultures? I think, yeah, they're going to do a set of blood cultures. I said, okay, have you gone onto the sepsis pathway? Oh, no, I missed that in orientation in my first week. And around we go. And so, look, this is what we need to be thinking about. This is a bundle. Perhaps if you spend some time tonight going through the sepsis pathway, later on when you've got a spare minute, you'll see why it's so important to actually be using these pathways, which helps everybody, the nursing staff and you, to make sure that you've got the appropriate workup. It's not just about the infection. It's also about the sepsis and understanding how severe that sepsis is, which impacts on the patient care. Pretty much every week I have that conversation. This is really interesting data, and I'd love to tease it out a bit more. This is data from our National Antimicrobial Prescribing Survey, which is a platform which is run through the National Centre for Stewardship, pretty much most public hospitals will have partaken in the NAPS, which is an annual point prevalence survey where every patient on antimicrobials is evaluated. And Australia is unique in that we actually measure appropriate, not just guideline compliance, because coming back to guidelines again, many of our patients don't fit a typical guideline. For example, the immunocompromised and other complex patients. And so we look at the aggregate measure or a matrix measure called appropriateness. And what's really interesting there is that you can see the principal referral hospitals, 88.6% for sepsis indications, whereas if you come down to the small rural regional hospitals, it's 70%. What do you think is going on there? What do you think is going on there? Well, first of all, we know that principal referral hospitals have 24/7 EDs, highly functional ICU. All principal referral hospitals have very robust stewardship programs. They potentially have sepsis pathways in place. They will all have infectious diseases and microbiology on site. And as you come down that size and down to the Group D hospitals, they have progressively less resources and access to the expertise. I think this is a systems issue here that will be not just around about antimicrobials, but it's also about sepsis care. And so for me, it's really important that we recognise the challenges of the Australian healthcare system. Our best care cannot be. We know that there is inequity in care across Australia in our rural regional hospitals. So how can we embed stewardship into sepsis? And it's not too tricky, really. You can think about in recognition that, first of all, we know in order to meet sepsis criteria, you actually have to have an infection. That patient is going to get antimicrobials. It's a very simple principle that I tell my residents and registrars. If you are thinking about starting an intravenous antibiotic, always do blood cultures. And we say 2 sets of blood cultures because we know the evidence supports a larger volume of blood because you have a better pick-up of bacteria. What about resuscitation? Well, it's not too hard. I can't imagine a hospital with a sepsis guideline that doesn't have the empiric prescribing recommendations. But they can be built out to take into account patient allergies. You may or not be aware that 1 in 5 patients in Australia has an allergy label, and the true rate is probably 1%. What does that mean? Well, every time you start and they come in, we've got a penicillin allergy, the first thing they get is ceftriaxone. So always leads to this broader and inappropriate prescribing. So our guidelines should take into account allergy. Hospitals should have some allergy delabelling in place now, severity and dosing recommendations, particularly to support the nursing staff. Empiric guidelines should take into account what the local formula is, and also, as part of our stewardship program, highly restricted antimicrobials or standard approval process should be in place. And then, of course, the question of timing, and I'm not going to go around and round about timing, but typically if you have a sepsis and infection, we're expecting antimicrobials to be administered within 60 minutes, and that takes a team to do that. It's not just writing it up, it's actually ensuring that it's actually given. Then in terms of escalation, it's fairly obvious that if you have a patient with severe sepsis, that they need early review and early inotropes, which is my point always about the fact that it's not just about antimicrobials, and our prescribers need to be aware of that there needs to be source control, early surgical review, and of course infectious disease review, particularly if a patient has risk of a multi-drug resistant or recent travel, or they've come from an endemic country. It's really important. And then finally, the post-acute phase. What happens in 24 to 40 hours, 5 days? They all have an infection, therefore there will be an associated treatment course with that. Once the sepsis is resolved, can they be stopped? Can they be de-escalated? Can they go home on a hospital ambulatory program? What about the communication? Again, really important, because behind the sepsis there's the infection, there needs to be education around that as well as the sepsis, and then the post-discharge planning, the so important transitions of care which Fiona talked about. And really to do that, sepsis clinical pathways are perfectly well placed to embed those principles through. My last slide comes back to this systems approach. And I've become very enamoured with this concept of a learning healthcare system. A learning healthcare system is about bringing together the clinicians, whether they be medical, nursing, intensivists, ED physicians, pharmacists, management, and patients, together as a learning health community to design the best way forward in terms of sepsis. And in fact, the clinical care standards, and I was on the working party, was exactly that. We came together as a learning health community to come up with the best standards we could think of that could be applied across our healthcare system. And I've coloured the one in red, coming back again to that point. We need to get data. And we need to get data because the data is what drives our knowledge. And once we get the knowledge, we can apply that as computerised decision support or clinical pathways and guidelines and toolkits. And then the knowledge drives practice, and then the practice again around and around, and with a continuous improvement. This is not going to happen overnight. It's going to take many years, but hopefully if we can all come together and swim in the same lane, we're going to get there.
Fabulous. Thank you, Karin. Now, we are getting a bit over time, so Brett, I'm going to go straight to you and just see if there's any questions or...
Sure.
Oh, we've been given 10 minutes. That's good. 4 minutes.
4 minutes.
Sorry. Yeah.
The main point that was picked up on was what you were saying, Karin, about people should really have a default suspicion around sepsis if they're unsure and there's a likelihood of infection. So rather than having to rule sepsis in, rule it out. Take the blood cultures early, just assume, okay, there's potentially is a sepsis case, and then go from there to try and get that care instigated very quickly.
Yeah, okay. So just, we do have a few minutes, so I'm just wondering, from what you heard, Medea, and your experiences in Pakistan, I'm sure are quite challenging in respects to antimicrobial resistance and stewardship in sepsis. So what happens in Pakistan, or at least in your hospital and your experience?
So you'll see both. Mm-hmm. So if the sepsis is not recognized at the first place of contact, obviously there will be a delay in giving antibiotics, even if the patient is not recognizing. It takes days and days to reach the hospital, so you'll see delay. Whereas on the other hand, in the hospitals where everybody is aware and they recognized and they want to over-prescribe, especially the surgeons after surgery, they want, it is always over-prescription. So you see both. So it's very difficult to strike the balance, but we are striving.
And that's what I'm sure, well, Simon and Karin, it's something similar here really, is that striking the balance.
Well, Karin has lots of data, so I shouldn't in any way argue, and I'm not arguing, but the experience around the world where people are collecting data after they've instituted a sepsis pathway is not of a vast increase. In fact, commonly either a static or even a reduction in the total amount of antibiotic used. And I was asked this again in the Concord thing. It's always comes up, well, there's this conflict between treating sepsis and antimicrobial stewardship. Well, and I think you called your thing two sides of the same coin. It shouldn't be, because if someone's got an infection, you're going to give them antibiotics. And as you said, you've got to have an infection to have sepsis. And if you're the current sepsis guideline, the Surviving Sepsis Campaign guidelines and the clinical care standard matches it, which is where you have doubt that you think someone's acute presentation or deterioration may not be due to infection, and they are not shocked, then a period of rapid as you can investigation to determine is this sepsis or a non-sepsis, is this infection or a non-infectious cause of this. And the other critical thing is the review. That's it's the people who've had the antibiotics started and are still on them because nobody's actually reviewing it. And I'm sure it never happens in your hospital, but it does happen in quite a lot of hospitals that, it's, within the standard says it must be reviewed within 48 hours. And obviously, if you think someone's got sepsis, they should be getting reviewed a lot more rapidly than that. So it's not just the starting, it's the stopping. But the data from around the world does not support the contention that there's a vast increase in the amount of antibiotic when you institute a sepsis pathway or a vast increase in antimicrobial resistance.
Completely agree. The Victorian pathway, we saw a significant fall in patients managed on a pathway. You have less ICU, shorter length of stay, and reduced mortality. So if you're not going to ICU, shorter length of stay and early review, you inherently should not see a rise in antimicrobial use, and you don't. So you should be able to see more appropriate use as well as shortened courses overall. So that's what I would expect to see.
Yeah. Okay, well, unfortunately, we need to wrap up this session. And I just want to say thank you to each and every one of you for sharing your stories and your wisdom and your knowledge around sepsis and antimicrobial resistance. And obviously, today is a very special day for us in that it is World Sepsis Day. And so just before we finish, I'd like to ask Simon to make a special announcement. And there's a slide that should come up.
Can I have a slide to make a special announcement about? So yes, we are rebranding the Sepsis Network, which is, as I say, a network of anyone who is interested is becoming part of Sepsis Australia as a bit of a rebranding, and we're doing so much more than we were, and this is happening from today. So at least when people want to Google sepsis and they're in Australia, if nothing else, they will come across Sepsis Australia, and there will be lots of resources. There are resources for clinicians, etc. And it's a multi-pronged program. And I would like to recognise, I'm not sure I can recognise you, Medea, in terms of Australian sepsis, but you in terms of your role in the Global Sepsis Alliance, but everybody else who is on here, Brett especially, who runs the Australian Sepsis Network as it was, and will now run Sepsis Australia and the Asia Pacific Sepsis Alliance, for the phenomenal amount of work that all these people are doing, and not to lose track of what we're trying to do, which is improve outcomes for our patients, particularly their post-sepsis outcomes, which have been totally neglected. So I'd also like to say thank you very much to the audience for staying. It's been a very long day. I think it's been a great day. I'm going to go and make the hospital become less carbon intensive, and I'd like you all to go back and do that and help improve sepsis outcomes. So thanks very much.